The average per capita lifetime health care expenditure is over $316,000, bringing skyrocketing health care costs back to earth tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. Providing health care for the United States has always been a two-pronged problem. One, get everyone on some form of insurance, and two, control costs and reduce them where possible. The costs are the question we'll be focusing on tonight. First, though, let's take a look at this week's question. This Prairie Doc quiz question is true or false? Higher health care spending in the U.S. is driven by greater use of medical technology and higher health care prices, and not driven by more frequent doctor visits or hospital admissions. Is that true or false? We'll have the answer at the end of the show. Joining us tonight is Dr. Tom Dean, good friend, frequent visitor as a guest on this show. He is employed by Horizon Healthcare and lives in Wessington Springs, South Dakota. Welcome, Tom.
Thank you.
So I call you an expert, and you are. You're the regional expert. I mean, I appreciate your knowledge. What is it that's given you that knowledge base?
That's hard to answer. I've joked that my family thinks I have some kind of serious character flaw because I find this stuff really interesting.
Yeah.
But it's always been an interest and something I've always just been attracted to understand how does the system work and what makes it run and where does it not work.
And you were the leader of the state family physicians for a period of time at which time people nationally understand. It was that brought national people to understand?
I was interested in the policy issues quite a long time before that. But
and then you became a member of MedPAC. Tell us what that is.
MedPAC is the Medicare Payment Advisory Commission, and when you hear PAC, you assume Political Action Committee,
but
it's not. It's a branch of Congress that advises Congress on Medicare policy, and so I was a commissioner with that group for 6 years. Many trips to D.C., got deep into the weeds about Medicare policy, and learned a lot about the Medicare program, which is a big, complicated program.
So our whole story tonight is that of costs. And the cost of health care has been said in the United States twice as much as the average cost of the very next 10 most expensive countries in the world. Is that right? And what are these costs?
The next closest to us is Switzerland, which is about 2/3 of what we have, but on an average, the wealthy countries in Europe and Canada and Australia and that make up the countries we're compared with are about half of what we expend per capita, yes.
And so what is that?
I've got it here. It's around $9,000 per capita at this point in time.
And I've heard that per capita Medicare is $12,000 per person. Like
could well be because the Medicare population is older and requires more care. So yes, it's probably true. I don't know that number, but
there are people who have said that the dollar amount that we spend, a lot of it is waste. And I've heard numbers from 30, 40, 20%. Do you have a comment on that?
Well, I mean, it's obviously a hard thing to quantify, but the 30% number, I think a number of independent, really sophisticated researchers have tended to come up with numbers right around 30%. Yes.
And where is that waste from?
Well, it's procedures that really don't benefit people. It's
back surgeries that are inappropriate.
It's doing extra x-rays, extra scans, prescribing expensive drugs that really don't necessarily help people. So there's no single answer. We do
of where the waste is.
Yeah, there's a lot of waste, and well, that's basically.
But it still leaves us higher than even Switzerland.
Oh, considerably higher, yeah.
You know, the Commonwealth Fund report indicates that the cause of higher spending in the United States is from excessive use of medical technology and higher prices for anything medical, all while there are less doctor visits and hospital admissions.
Yeah.
We have a slide that talks about the cost of health care. Let's look at the first projected image. Explain this graph, Tom.
The top line is the numbers from the United States, and that conglomerate of colored lines are the data from these other, I think, 12 countries which make up the OECD, which is the Organization for Economic Cooperation and Development, I think. Anyway, that share social data. And for a long time, we have both had higher costs, and our costs have gone up more rapidly than these other countries, which are basically wealthy countries that most of them have universal health care. Right. So they spend less, and their rates have gone up more slowly than ours.
Okay. So that Commonwealth report that talks about medical technology and higher prices, let's understand that a little bit better. Medical technology would be like what?
Well, we have remarkable technology, and a lot of it is important and has made great contributions. So we're not anti-technology, but we need to understand when and be much more critical, I believe, about what does that particular procedure offer to the patient, and is that the best way to get the information we need or to attack the problem that they may have? And we've not been as careful as we should be about that.
I made a big fuss in my clinic and in our hospital maybe 15 years ago, 20 years ago, when we were starting to CAT scan everybody's head, when everybody came in with a bump on the head, and when do you CAT scan the head or not? Everybody was getting it if there was one slight hint of a problem, and we know that that's waste. I mean, that's inappropriate use of technology. On the other hand, one person told me the story, okay, he hesitated, he didn't do the CAT scan, and then the kid came back the next day. They did the CAT scan, there was subdural hematoma, and the family was irate. So he's always doing the CAT scan. He looked at me in my face and said, I'm always going to do it.
Well, that's the problem.
There it is.
Because on the other hand, the factor that's not factored into that assessment is CAT scans are not benign. They're
radiation.
They contribute a lot of radiation, less now than they used to. And then just the cost issues. But the main issue is we need to be more clear about what information that's going to provide, and what is that the best way to get the information we need.
Right. I have understanding that when people come to the emergency room with abdominal pain, sometimes before the patient is even questioned and examined, the CAT scan of the abdomen has been done. That's inappropriate in my sense. Well, the other reason they talked about was the higher prices for everything. That's the price of going to the emergency room is gargantuan. The price of a Tylenol in the hospital is, why would that be? What has driven the prices up?
Well, the hospital pricing is a very complicated issue, and even the hospital people will tell you that. They don't get paid for a lot of the stuff that they do, and so they push up the prices on the things that they are likely to get paid for to try to balance out the budget. And so it's as simple as that. There's an interesting study recently at the University of Utah tried to analyze exactly what every element of their care actually cost. And they had a devil of a time trying to figure out what it actually cost. And they've done it, but they figured out what every bandage they use in the operating room actually costs. And they showed that data to their surgeons, and their surgeons said, "Oh, I didn't realize that." And
I could have used this cheaper thing.
I could have gotten by with a fewer than that. And once those data become clear, a lot of times we find that we really don't need to do a lot of the things, and that it really isn't helping us. If that's needed to help the patient, then yes, we do it, absolutely. But too often we do a lot of things that are not. And I think the other thing that's really that is really striking, a lot of the countries that spend significantly less than we do people see their physicians more often than people in the U.S., and they spend more time in the hospital than we do, than people in the U.S. do. And one of my concerns is that we have put so much emphasis on length of stay of hospitals in order to try to control costs, that we have packed so much into hospital stays. They've gotten so complex and so concentrated. Yeah. And especially when we're dealing with an increasingly elderly population, they just don't get well that quick.
Well, and
so it makes it interferes, I think, with the natural history of some of these diseases.
Well, and they're asking us to send patients home quicker, but at the same time, but not let them come back again.
Yeah.
So then the emergency room is trying to send them out.
Yeah.
So we're not, and then they get sicker, and then they end up with a catastrophic illness that's
The
expensive.
critical thing on there, and you and I have talked about that, is that if a person is stable, they may not need to be in the hospital, but they do need to have care, and they need to have a plan for how is that follow-up going to be made. The thing that the study that put the huge emphasis on hospital readmissions was done about 10 years ago, and showed that I think it was 25% of people who were discharged from the hospital were readmitted for the same diagnosis within 30 days. The real critical part of that study was that half of those people had never seen a doctor in the meantime. They went out of the hospital.
They didn't have a follow-up?
They didn't have a follow-up appointment. They went out of the hospital, they got sicker, and they came right back in the hospital. Whereas now, hospitals have put much more emphasis on trying to make sure, because they're going to be penalized for those readmissions.
Well, and you talk about taking your medicine and seeing your doctor, but if you do take your medicine, the cost of the medicine keeps you from buying it. And the cost of the visit to the doctor keeps you from going to the doctor. Do we have data that says that affects the patient fill prescription or appointment rates?
All too often, the cost of prescriptions has stopped people from actually picking up prescriptions. Even, I just read a report today that even things like cancer drugs, there was a story about a fellow with a cancer, and it was going to cost him $3,500 for his copay on this thing, and he says, I'll probably be able to do it, but I got to put it off because I can't pay that today.
Yeah.
And so
he ends up in the hospital, a much more intensive.
Well, I don't think it's going to end up in the hospital. But the point is, he put off something that could have been really dangerous for him.
Right.
Yeah.
One more point, and then we're going to take a little break. But the cost of care in the U.S., many people have said, is skyrocketed because of administrative costs. And I know there's a lot more administrative people than there used to be. I mean, we have rolls and rolls of people that are doing health care oversight, required oversight. They're bugging me about urinary tract infections in the nursing home. They're looking at the medical record and making sure the record, and all of the IT people, all of this administrative stuff. What do you think about the cost of administration as the reason for the cost of
It's a huge issue, and it's an issue that hasn't gotten much attention. In all our attempts to make sure, especially the payers, the insurance company, in all our attempts to be sure that people are actually doing the things that they're billing for, we've had all this extra documentation. And but the international comparisons, I have it here someplace, that the per capita cost in the U.S. is about $600 compared to Canada, which is $148. And there was another interesting study that looked at physician practices in the U.S. and Canada doing basically the same thing.
Right.
The pure administrative cost for the U.S. physicians was 4 times higher than it was for the Canadian physicians, doing the same kind of medicine.
So what about Medicare? That's government. I mean, that's got to be much higher than administrative cost.
Actually, like I said, I was on this the MedPAC Commission, and we got deep into the weeds about those issues. Medicare is an efficient program, surprisingly. A lot of people don't realize that. Overhead costs in Medicare are about 4%, whereas most private insurance companies operate around 15%, anywhere from 12 to 20%. And since Medicare actually pays less for each procedure than most private insurance companies, $1 invested in Medicare actually buys you more care.
More health care.
Yeah. So Medicare, we hear that Medicare is going broke, and In fact, the introduction or the passage of the ACA, Obamacare, actually extended the life of the Medicare Trust Fund about 12 years, I think it was. Actually, when the ACA was passed in 2010, Medicare was projected to become insolvent in 2017. That's now.
Right.
And now the projected insolvency is about 2028, which is still way too close for something as big as that. But
the ACA slowed down
the ACA
insolvency.
extended the ACA extended the life of the Medicare Trust Fund.
It slowed down the acceleration of the cost.
And the problem with Medicare is not so much the cost, although that is a big problem. The difference is that we have many fewer people paying into the trust fund, and we have many more people
Going into it, yeah.
using
The
the money
boomers.
out of that trust fund.
Here come the boomers.
So there's a big imbalance, and that's no fault of the program. It's just one of the demographic problems that we have to deal with.
While the cost for providing some form of health care insurance is high, the cost of not providing it might be higher.
I think the reality is that we have the most amazing health care in the world, to be honest. And our foreign doctors that work here, who come from countries where on paper it says that the outcomes are better than they are in the U.S., would tell you that if their family members get sick, they're bringing them here. We have more stuff, more capabilities, more research and such than most of the countries in the world, but we don't have access for everyone. And in the bulk of competitive countries with us on healthcare outcomes, they have coverage for everyone. And whether that comes through the private sector or through government, that access allows everyone to get into the system sooner. I think we also have more access than most countries in the world, and access means availability, and so I think people use that more. I think that, when we have symptoms, we check into them quicker, and I think the other side of access is that people that are uninsured or have less insurance perhaps than they feel comfortable with wait on things, and oftentimes things that could have been dealt with fairly simply earlier on are overwhelmingly challenging and require a tremendous amount of resources. Technology has driven our costs up quite a lot. It's a very complicated subject because of the things that we can learn from CAT scans and MRI scans, which are very expensive compared to traditional x-rays. Oftentimes we can avoid surgeries and such that were done in the past. So from a cost standpoint, in the long run it's cheaper, perhaps, but having the technology means that it gets used quite regularly to rule out things. Well, the most expense, honestly, is pharmaceuticals, and primarily in oncology drugs. There are many oncology drugs that are $10,000 and $20,000 and $30,000 per month, and when you consider that treatments can be months to years, that can be an overwhelming number. Many times our inability to be there early with chronic conditions like diabetes or such result in significant illness later on, or much more developed problems that require much greater attention, and that may require surgical interventions, it may require more pharmaceuticals and such, and all of those things have significant cost. Well, the most expense, honestly, is pharmaceuticals, and primarily in oncology drugs. There are many oncology drugs that are $10,000 and $20,000 and $30,000 per month, and when you consider that treatments can be months to years, that can be an overwhelming number. I think many times our inability to be there early with chronic conditions like diabetes or such result in, one of the challenges was that we knew when the healthcare exchange came out and we were able to insure a lot of people that hadn't been insured previously, that there would be pent-up demand. The government had promised us that knowing there would be pent-up demand, that they would actually reimburse us for what would be considered that the costs of that pent-up items that needed to be dealt with. Congress came back later and said, we can only afford to pay 12% of that. And so that meant for the Avera group that it cost us over $30 million that we were not reimbursed by taking care of folks that under that plan. United Healthcare, it cost $700 million that they lost because of that. So in some ways, the government didn't live up to this transition time. We felt that once we got through the transition time that actually it could work quite well. It's frightening when you think about having a $10,000 deductible on your insurance plan if you make $12,000 a year. That might as well be $1 million to them at that point. So I do think that giving people comfort that they can get into primary care early and get address needs, address chronic conditions in a way that avoids the travesties that happen downstream that require hospitalizations or surgery or amazing medications would be very helpful. As an example, a single mom with 2 or 3 children that works 2 or 3 jobs just to get by, but all part-time, so she doesn't get coverage from any of her workplaces. That puts her in a really tough spot. She may make enough money not to qualify for some of the support mechanisms, although she deserves to be supported with all of the work that she's doing to make her family work. So I think that we can do that better, but maybe that's more of a tweak than it is a total upheaval of what we're having today. Without that, we are going to have people on the outside, and at some point they will cost significant amounts of dollars just to care for their tragedies or travesties, as opposed to getting in early in the front line and being able to help them with issues before they develop into something bad.
Now that was the head of Avera McKinnon Hospital, and not only a very, very smart man, but a very kind gentleman, and you can sense that by the way he spoke. He talked about a bunch of things we should address, but one of them was the issue of no matter what you do, right along you're healthy as you could be, and then suddenly you come down with an illness. Now, I mean, you and I have both. Tell me about your illness.
Yeah, I have cancer. I have a disease called multiple myeloma, which is kind of like a leukemia. It's a bone marrow cancer.
The plasma cells in the bone marrow, yeah.
And I thought I was perfectly healthy. I did mostly the right things. I probably ate too much, but other than that, I didn't have any other risk factors. Yeah. And I assumed that I was in good shape, and all of a sudden, in the course of about a week, I found out that that was not true. And I've had fortunately, it has responded well to treatment, but has been outrageously expensive. Yeah. And I think your experience is somewhat similar.
Well, right. I mean, I came down with abdominal pain. I mean, I've lived the perfect life. I mean, I've exercised on a very regular basis and not excessive in any form or manner, and come down with pancreatic cancer.
I think the key lesson there is here are 2 of us that knew the risks, and we did what we were supposed to do. We both ended up with bad diseases.
Thank God for insurance.
Thank God for insurance. And that's why, you know, people say, oh, I don't need it because I feel good. Well, I felt good. And a week later, I found out I had a life-threatening cancer. This was 8 years ago, and I've done very well. But
let's talk about insurance. I mean, one of the things that the ACA tried to do was to say, okay, we're going to have insurance for everybody. Everybody can get it, and everybody should get it. And they were going to require the young people, and of course, a lot of that got pulled out from underneath it, and the ACA didn't require the young people or all people to get it as well as they could have. Yep. And that was a bad deal for the insurance industry, because you can take care of the sick 5%, 50% of the healthcare dollars spent on that 5%.
You and me.
Yeah. And then 50% of the people on the lower side
Yeah.
account for 3% of the cost of health care.
Yeah. Isn't that crazy? I
But
mean,
that's why you have insurance.
but any one of those 3% I went from that 3% to the 5% of the highest cost patient overnight. And so
You can't know when it's going to. That's why we need to have insurance.
that's
if
why
we're
insurance is so important. Yeah.
So if we had a single payer system, then the government would be the insurance.
Yeah. Which is basically what Medicare is, and Medicare is basically pretty successful. But it has its challenges for sure.
Let's talk about another issue that Dr. Kapaska brought up, and that was pharmaceutical costs. He said that's a huge thing for them. I mean, we know the cost of 2 EpiPens is in the $380 range with the ingredients that cost the company $2.
Yep.
Reflecting how the costs of many medicines are inflated by pharma for profit. Generics aren't even much cheaper anymore. Often drugs developed in our public universities are patented, and costs continue to be outrageous even though we paid for the development.
Yep.
Why has this happened? Is there anything we could do to fix it?
Well, I brought along a prop here.
Okay, let's see it. All right.
This is the drug that I take, which has been a remarkably effective drug. It's easy to take. It's a pill. It has relatively few side effects, few nuisance ones, but nothing important. And it has revolutionized the treatment of myeloma. At the time I started taking it about 8 years ago, it was $8,500 a month, right at $100,000 a year. It is now something over $12,000 a month, right at upwards of $150,000 a year. And so the company clearly recovered their development costs within a year or two, and yet the prices have continued to go up. And the dilemma is that there is no competition. This is a marvelous drug. It's very effective, and it has no competition. So it's a true example of what we call market failure. That's what the economists would call it, because the company is treating. I mean, the drug is treating an important condition, a life-threatening condition, and they have no competition. So the sky's the limit. They can charge whatever they want.
Right, and the EpiPen is another example.
EpiPen is,
but why? Do they have an ability to do that? There are laws and rules and regulations that have made them able to have the market.
It's a free market. It's a free market, and so they can price
whatever they want.
Yeah.
But why isn't there somebody running to sell it for $10?
Well, because right now, this drug especially, and the EpiPen 2, are both patented, and so they have exclusive rights to them for about 15 years. In the case of EpiPen, what's patented is the delivery device. The drug is been around for hundreds of years.
But you can, if you asked your doctor, you could get a prescription for epinephrine and a syringe and learn to give yourself that and save a ton of money.
Probably cost you $5 or $10.
But you're not driven to do it because insurance covers it.
Yeah.
So that's another issue, competition. I mean, competition is one of the things. My friend Tom Dempster, the person who did these photographs from Sioux Falls, was a senator and believed, and I think he still believes, that if we shared the cost of whatever it is that we're having, an appendix surgery, delivery of a baby, if that was open and transparent, then people could shop around and find the best care. Do you think market competition could work if we would shop around?
And that's been looked at, and it basically doesn't work, unfortunately, because we'd like to think it could. And perhaps if you bought a whole package of services and you had companies or systems competing for total packages of services, that might work. But for individual services, for instance, I was joking the other day, have you ever seen one of the healthcare systems advertise that we do the cheapest appendectomy?
Yeah.
I mean,
no.
It doesn't happen. First of all, it would scare people away.
Right.
Even if it was, because the public believes, unfortunately, that if you pay more, you're probably going to get better care. The reality is just the opposite. Most of the really good systems actually charge less than the ones. And the best way to reduce costs, from one perspective, is to do the right procedure, do the right tests, don't do any more than that, get the patient well quickly, and you'll save costs. Whereas if you have lots of complications, costs go up, and unfortunately, hospitals get more money, doctors get more money, and it isn't, and I don't in any way mean to imply that anybody would be driven by that, but the reality is that oftentimes the things we need to do to save money actually cost the provider. And just, I'm getting long-winded here, but for this issue of readmissions, after we talked about it a minute ago, hospitals have been forced to spend money to reduce their revenue because they are spending money to prevent those readmissions, but those readmissions brought money into the hospital, and they're trying to prevent that. But so they're spending money to reduce their revenue. That's not a good business plan.
You know, the whole thing is crazy because of third-party payers.
Well,
you know, if you went to the grocery store and you said, okay, tonight I'm going to have steak or I'm going to have hamburger. Well, no, hamburger's too expensive. But I'm going to have chicken.
Yeah, okay.
I mean, okay, so well, I don't have a lot of money and I would be just as happy with chicken.
Yeah.
Or you pick the price of, do you do the brand name of butter or do you go with a generic butter or whatever it might be? The generic used to be a way to pick a cheaper thing.
Yeah.
Even the generics are more expensive now.
Yeah, yeah.
But competition, so you don't really think shopping around, I mean, it doesn't work if you got an acute appendicitis. You go to the emergency room and you go, whatever.
And the other problem, or another part of that problem, is if you try to shop around, it's really difficult to know to get actually quote on the prices because the providers have a lot of different prices. Hospitals negotiate with insurance companies. A lot of the imaging companies negotiate with. So what they list as their price, the insurance company will pay usually substantially less than that because they've already cut a deal with them. And yet the individual that goes to try to find out what is that going to cost me, he might get a quote, but
that's not the real price.
But it's not the real price.
So it just doesn't work. In other words, you and I both agree, unfortunately, the competition thing doesn't work.
Yeah.
Look in Sioux Falls. There's two very competitive systems. What has that told us?
That was a shocking. There was a bit of a large database became available just within the last couple of years, which finally provided the actual private insurance expenditures in the 300 hospital referral regions that some of the researchers have set up. They've broken down the country into these referrals. And Sioux Falls, for many years, was regarded as a relatively low-cost area based on Medicare data because the expenditure for Medicare is relatively low and in the lower quarter. But when they looked at the expenditure from private insurance, it was near the top. It was 14th out of 306 hospital referral regions in terms of the cost of private insurance. So even though you have this aggressive competition,
it didn't change.
And it's easy to understand because they don't compete on the basis of price. They compete on who has the newest technology, who has the fanciest gadget, who has the nicest building, you know, all that stuff. But they don't compete on the basis of price, which if you're a grocery store, you compete on the basis of price. If you're selling cars, you compete on the basis of price. But in healthcare, that doesn't happen.
Well, and let's look at the price of healthcare in parts of the country when they've looked at quality. My sense is that the quality of healthcare in the United States is pretty high in South Dakota, partly because of the competition in Sioux Falls. Mm-hmm. It's that driven quality.
Yeah, both of those systems that I was just knocking give good care.
They have really good care.
They both give good care, absolutely.
Okay, and in fact, if you look at the health care in South Dakota and Nebraska, North Dakota, Minnesota, we're in the center of some of the best care. Hawaii is an outstanding leader, but we are the center for high quality and lower costs.
Relatively, although the problem
Medicare.
is, I'm interrupted. The problem is most of the cost data is still based on original Medicare data. It's not based on some of this newer data that I looked at. So I'm not sure about that.
All right, but what about the highest areas in the United States, most expensive places?
The most expensive places are in the South, Texas, Louisiana, Mississippi, Florida. Those are the highest cost places, and the measurements of quality outcomes, they are at the bottom. So the correlation
of cost
and quality is almost the opposite of what you'd expect. The highest cost places tend to have some of the worst outcomes.
So there's one other competing system idea that might be something worth dealing. And you hear politicians talking about opening the state lines, letting insurance companies compete. What do we know about the state line? What data do we have? What scientific data do we have that would suggest that state line?
Yeah, that's very
would help
appealing to the politicians.
It sounds competition.
It sounds like competition. In fact, it's a completely bogus idea, and for two reasons. First of all, the insurance companies are not interested. There are 5 states in the country that allow that right now. They've not had a single application from
outside there.
From an outside insurance company. And the reality is it could even be negative because regulation of health insurance is now and always has been a state function. And so in order for the selling across state lines that they're always talking about. First of all, any company can sell in South Dakota. They just have to get a license from the South Dakota Insurance Commission, which will check their solvency, it'll check their backup reserves. Right. And if you have a problem with your insurance company, your first line of defense is the state insurance commissioner, because you
right.
can go to them and they will lean on the company if you have a legitimate gripe.
Right.
If this was this proposal that we keep hearing about were actually to happen, the federal government would have to invalidate all of that, would have to overrule the state insurance commissioners and say you are responsible to the insurance commissioner, presumably in whatever state the company may come from. So if you buy a policy from some outfit in Texas or New Jersey or someplace, and you don't either the company becomes insolvent, which can happen, or if a claim doesn't get paid, you're at risk, it's their insurance commissioner that you'd be
having to call to. And New Jersey isn't going to be excited about talking
I
to
don't
the
think
guy
they're going to be very excited about South Dakota. So I think, unfortunately, it's appealing from a talking point of view, but as far as a real offer or real benefit, it just doesn't have any.
Okay, and I'm going to talk about in Texas, largely because of the abortion debate, and this discussion has nothing pro or con about abortion.
Right.
I'm not talking abortion. But because of the abortion debate that occurred in Texas, cutbacks have occurred with all services, including non-abortion services, which are provided in women's health care clinics, and thus had reduced availability of health care to maternal situation, women who are pregnant, and decrease the availability of inexpensive contraception. Yep. The result of those cutbacks has caused, since 2011, a doubling of the death rates of women during and after childbirth, mostly in the low-income minority women, which is very expensive when they're in that process of dying. Think about the money that they would pour into that. What does this say about making efforts to reduce costs?
That particular bit of data, I think, is the most alarming statistic that I've seen anytime recently, that the rate of infant mortality, or not infant, maternal mortality, mothers
right.
dying in childbirth.
But you know that it's also infant mortality.
Well, the infants probably died too. Has doubled in the last 5 years. I mean, unfortunately, it's going up across the country, but it's way worse than, there's a huge disparity between states. But
what are those clinics called? Those are called, what is the name of the clinics that provide prenatal care and all those
There's a number of federally supported clinics through Title X. There's Planned Parenthood, which has been a big contributor in this area. Planned Parenthood has taken a huge amount of criticism because they do provide abortion services, although it's only less than 5% of their services. But if you take away the other services,
the 95%,
the other 95%, this is what leads to these really horrible statistics that more women are dying in childbirth today than were 5 years ago. Twice as many, actually. We're verging on the same statistics that Mexico has.
You know, and so we're not talking about pro-abortion or con-abortion. No. We're just talking about what's happening when you lose Planned Parenthood and women's health services. That should be something everybody should promote for free.
And in fact, if you take away the contraceptive services, probably the number of unintended pregnancies will go up, and probably the number of abortions will go up.
So the paradox is, you take away Planned Parenthood, more abortions will occur.
It's very likely. I mean, we can't prove that, but there's every reason to believe that that'll happen.
We're going to look at the efforts to try to control costs. If every patient had a primary care doctor or a primary provider, including every person might be an illegal immigrant, would that reduce costs?
I believe so. The systems that have a good, solid, well-established primary care base have lower costs and better outcomes.
You know, I think if you had a doctor or your nurse practitioner or PA, if you had one, you would go there first.
Yep.
Problem solved, instead of going to the emergency room, which is the most expensive, least efficient health care you're going to get.
And you would also have someone who would understand your total picture and could help to coordinate the input of the variety of specialists that may be involved. The specialists do important things, but they don't do a very good job at communicating with each other. And so very often, you know, you and I both see patients that have multiple different recommendations and may or may not coordinate with each other.
We're going to want to look at slide number 4 on social workers. One of the things that other countries have are social workers to help coordinate what kind of disposition, where the patient goes, when you can find a doctor to go to, what kind of support do you have, and so on and so forth. Explain the slide that we have here.
This shows the proportion of expenditures that various countries do on social services, social care, as opposed to health care, medical care. The lower gray bars are the proportion that they spend
on healthcare.
On healthcare. The dark blue bars are what they spend on social services.
And we're yellow.
We're yellow. We spend a greater proportion of our overall expenditures on medical care and a smaller proportion on social services. And where this comes into play, there's been some really interesting studies. Hennepin County Medical Center in Minneapolis, which deals with the low income, the uninsured, the drug addicts in Minneapolis, had a number of people that were homeless and ended up coming to their emergency room
time after time.
And so the hospital actually took a group of these people and actually paid for apartments for these folks in order to give them a decent place to live and some other services, and they saved money.
Save money by buying them or paying for an apartment.
By paying for an apartment. And so it says that when you provide adequate levels of social services,
there it is.
The healthcare costs go down. And when we're dealing especially with homelessness and another big worry about some of the new proposals for healthcare is that probably addiction services will be cut back on. Those are going to increase costs in other areas because the addicts are going to end up in the emergency room, and it's just we just got to be careful that we don't squeeze the balloon in one place and get a big bulge someplace else.
That's a beautiful metaphor. In this world of hospitalists and referrals to multiple specialists during hospitalizations, which brings back to that primary care.
Yeah.
Wish we had more primary care, but we get into the hospital. There's hospitalists, there's hospitalization, it's multiple specialists. Is it improving care? Is it costing more? Is it decreasing efficiency? What's the goods and the bads of that whole trend?
Well,
you're a primary care doctor, and so am I.
We're biased.
We are biased, aren't we?
But there's good and bad. I mean, there's some places that handle it much better than others. But unfortunately, too often, we hear the reports of a person that was hospitalized and say he saw 6 different doctors and nobody ever told him anything. I don't know that that's always fair because, but at the same time, those are the stories we hear because they don't, too often when they get into the really complicated referral centers, there's a multitude of different people involved and nobody seems to really coordinate things. And I've been somewhat disappointed, and this may not be totally fair, but in the hospitalist movement, because I thought when it first started that they would be the ones that could coordinate the care, the patient could get to know them, and they would be the ones that could put all this together. Unfortunately, they work a shift and then they're off, and it's
a challenge.
Yeah, it really is a challenge.
You've been in the hospital enough, and I have lately, to realize that that social worker would be maybe the person to help coordinate, or that primary care doc or nurse practitioner.
And primary care docs, unfortunately,
are not there anymore.
They're not going to the hospital anymore. And I understand why that. I understand
it gives them a life.
But at the same time, I think it's an unfortunate development. Yeah.
So we're not against hospitalists, and we're not against subspecialists and all these people.
Absolutely not.
No, we like them.
My son is a subspecialist.
Is that right?
So
there. You got to be careful what you say.
And I respect him. He's a good doc. He's a nephrologist. But he and I have these discussions all the time.
Yeah. Well, we need to try to improve every time we turn.
He agrees.
How can we make this better?
Yeah, we've had. Some.
Let's talk about the big driver of the emergency room. I personally think that the emergency room sets the culture for the hospital. They're the ones that consult 2 or 3 people to start with. They're the ones that order the technology right off the bat. And they're the ones that are highest at risk for liability. So they end up doing it. I remember an ER doctor when I gave her some guff about having ordered the CAT scan and the excessive stuff on a patient that I had brought from the nursing home to the hospital to just peek at. She got a hold of them. All these tests were done before I got down there to see the patient. I didn't know that this was going to happen. And there was $5,000 to $10,000 worth of on a nursing home patient. I just wanted to, I put on an antibiotic, and there it was. Yeah. ER, what could we do to decrease the overuse of the ER who don't have an emergent problem? And how could we improve the excessive use of technology there?
It's a challenge, but I think to go back, and at risk of repeating ourselves, I think a good primary care structure is the answer. And there are some places that do that. I mean, there's a large organization on the, Group Health of Seattle, Group Health of Puget Sound, which now just became part of Kaiser Permanente, which is a gigantic. They showed that by really implementing the patient-centered medical home model, they cut down on their hospitalizations, they cut down on their emergency room use, and they save money, even though they invest. This is a totally integrated system where the patients pay a fixed cost and they get total coverage for everything they need. And they showed that even though their primary care investment went up, their overall cost, they save money on the other end. And unfortunately, most of our systems are not that integrated, and so they're trying to save money where they're at rather than across the whole spectrum.
And somehow the liability that those people live with has to be fixed. I mean, liability, the lawsuit of the physician, that's the place that needs the most help.
It needs help. I personally, of course, we're kind of fortunate in South Dakota. It's less of a risk here, and it's less of a risk out in the small communities where I'm at. But I think it's probably not as big an issue as people make it out to be. But everybody's scared because you read the stories, you talk to physicians that have been sued, and it'll ruin their life. Yeah. Whether or not it costs them a lot of money.
I've been sued. I couldn't hardly look at a patient for 2 years after that in my first years of practice.
And so those are just unacceptable costs. So they're personal, psychological costs, setting aside the dollar cost.
The insurance industry told us before the ACA was passed that the only way insurance can work, if we make a rule, is that if we're going to cover those with pre-existing conditions, that we would have to have everybody be insured. I think that's right. If you're going to take the sick ones, you got to get everybody to, the people who are well need to be part of the whole system.
And that sounds as though we're gouging the young and the healthy, and that we're taking advantage of them.
But that's what insurance is.
But that's what insurance is all about. Plus they still get a significantly lower rate, even if everybody was included.
So we got 30 seconds. It looks like the ACA didn't do real well on that. What about the Republican plan? Does it look like they're going to cover?
I think it'll do worse, because they are eliminating, they are maintaining the requirement that insurance companies cover everybody that comes in regardless of pre-existing, and they are eliminating the hated mandate, which I understand because everybody hated that requirement. But what it means is that you will have the group of people in the insurance pool is going to be sicker and sicker, which means that the premiums are even going to go higher. Because the premiums that insurance companies charge are a direct result of the cost of the care.
There it is. And now for the answer to tonight's Prairie Doc quiz question. True or false? Higher healthcare spending in the United States is driven by greater use of the medical technology and higher healthcare prices, and not driven by more frequent doctor visits or hospital admissions. Is that answer true or false? Tom?
The answer is true.
It's true. We Americans love our technology. We'll be right back after this.
All around town, from stores to playgrounds, babies are on the move. And there are diseases that are on the move too. And some of these spread easily. To best protect him from 14 serious diseases by the time he turns 2 years old, vaccinate him according to the recommended schedule. So he can go on about his business and you can have peace of mind. For more reasons to vaccinate, talk to your child's doctor or go to cdc.gov/vaccines.
The Patient Protection and Affordable Care Act, commonly called the ACA or Obamacare, could have been called the Access and Cost Act. It was successful in protecting patients by guaranteeing access, making insurance available for more than 20 million people who were not able to get insurance prior to the ACA. The second part of the name, Affordable Care, referring to cost, has not been as successful, however. Politicians have said, and this is correct, since the ACA was implemented, increases in health spending have slowed. Personally, I do not find this statement reassuring when looking at the enormous costs of health care in the U.S. We spend $3.2 trillion per year for health care, which is twice the average cost per person than that of the next 10 most expensive countries, and more than 5 times the outrageous $600 billion we spend per year on the defense budget. Individual costs also grew during the last 5 years. Patient deductibles increased by 63% and premiums by 19% during a time when worker earnings grew only by 11%. From an October 2015 Commonwealth Fund report comparing the U.S. with 13 other rich countries, the data indicates higher spending in the U.S. happens because of excessive use of medical technology and higher health care prices, while there were less doctor visits, hospital admissions, or spending on social services. Despite all the health care spending in this country, we have poorer health outcomes, more chronic conditions, and shorter life expectancy. It's like paying a high price at a fancy restaurant, expecting the perfect steak, and instead getting meatloaf. How should we fix the healthcare cost problem? 1, every patient should have and start with a primary care doctor or provider who emphasizes preventive care efforts and solid science-based quality parameters. 2, doctors and hospitals should lower prices and yet get more payment for efficiency and quality, not get more for doing more, specifically more procedures and more expensive high-tech tests. 3, a single, nationally interactive, easy-to-use, story-based electronic medical record system should reduce duplication and enhance coordination of care. 4, improved social services should help all people, especially the poor, in avoiding inappropriate use of the emergency room while facilitating good treatment of chronic conditions. 5, pharmaceutical reforms should allow marketing pressures and competition while encouraging honest research. And 6, medical management of the 5% of people who spend 50% of the healthcare dollar should allow better and less costly care. The ACA brought access. Now we need to control cost. A big thank you to our guest, Dr. Tom Dean, for coming to our studio tonight and helping us address this weighty issue with his wonderful expertise. Thank you very much, Tom. Well, that does it for tonight from all of us here at On Call with the Prairie Doc. Until next time, stay healthy out there, people. Good.
Well done.
can't get enough of the Prairie Doc? Then visit our webpage and other online programming. You'll find extended interviews with guests and more information on important medical subjects. Visit prairiedoc.org or follow us on Facebook. The best way to stay healthy out there.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
And by
the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota,
and with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
South Dakota State Medical Association,
Avera Heart Hospital,
Dakota Allergy and Asthma,
Fishback Financial Corporation,
Vance Thompson Vision,
Aberdeen Asthma and Allergy,
Black Hills Medical Society,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
Regional Health,
Swiftel Communications.